Okay, recording. Okay, welcome everyone. We'll get started. We've got a bunch of questions already submitted. If you'd like to submit questions, please type it in the Q&A. All right, thanks.
Okay, so some questions for today. We'll get started. You said we need width to fit in the front teeth and depth to fit in the back. Does this mean once you have room for the front incisors, you stop expanding the width and start focusing on the cat wires for depth? Or do you keep going with the transverse expansion when you still don't have room for canines and premolars? Yes, so generally the intermolar width needed for kind of average size incisors and canines is around 37, 38 millimeters from the upper sixes. So generally, once you get to that 37, 38 millimeters, assuming the teeth are kind of standard size, then you're not going to be able to expand any further without growing into a scissors bite relationship with the lower. So yes, we stop expansion at that point. And then if you want the canines to fit, then often you need more depth. So you'll start to use the cat wires at that point. If the teeth are very big, then you might have to go to 39 mils. If the teeth are very small, you might stop as early as 36, 37. So your guide is a combination of the size of the teeth as well as how much you can do in the lower. Once the curve of Wilson is flat on the lower, you really can't do much more. Unless they're quite young. Because once you get into, established mixed dentition, then once you flatten the curve of Wilson, any further expansion ends up tipping the molars. So you can't really do any further arch expansion than a flat curve of Wilson in an established mixed dentition arch. You might get a bit more if we're in primary only dentition. All right, so next question is, I've listened to your explanation in the previous Q&A defining true mandibular rotation. I'm still trying to understand it. I understand this term comes from Bjork studies using the chin as a stable point and then follow-up x-rays to compare the mandibular growth direction as either normal, open, or closed. So am I correct in saying that true mandibular rotation could either be normal, closed, or open, or does true mandibular rotation refer only to the normal rotation of the chin forwards and upwards? So rotation growth in the jaws can be a counterclockwise or a clockwise rotation, assuming you're looking at it from the profile in from a surgical perspective definition. So we've either got a forward rotation so that the chin travels in a direction that moves towards the nose, or a backwards rotation where the chin heads down to the chest. So they're the descriptions for the rotation direction. So the rotation direction is a separate definition compared to true mandibular rotation. A true mandibular rotation refers to the direction the chin ultimately heads towards. And that direction is either forward rotation or backward rotation. So if it's forward rotation, then you say the true mandibular rotation is a forward rotation. And if it's a backwards rotation, then true mandibular rotation is a backwards rotation. So the reason why it's labeled true mandibular or true maxillary rotation is to differentiate what appears to be happening in the normal cephalometric points because of remodeling. Right? So what appears to happen if you just mark the normal ceph points is different to what is actually happening to the stable points, such as the symphysis, when you account for the remodeling. So true mandibular rotation is done referencing the stable points so that it discounts all the remodeling effects that happen that mask the rotation direction. So true mandibular rotation can be backwards, it can be forwards. A true mandibular rotation refers to what's happening to the symphysis in particular, which is the most relevant to, the adult relationship in AP and vertically. All right, so one is referring to what happens to the symphysis, the ankle points, and the direction is termed forwards or backwards. Normal class 1 growth has a forward rotation or closing rotation, if you like, whereas malocclusions tend to all have a backwards rotation or an open direction. Closed and open is more applicable to posture, which is the driving force behind the true mandibular rotation direction. Next question. I'm watching your 21 mentorship course where you are reviewing level and alignment gone wrong on a case where it was misbracketed when trying to fix the deep curve of Spee. Can you explain how one should bracket these cases for the most efficient treatment result? For instance, you told her to place the brackets close to the incisal edge on the incisors on the teeth you want to intrude and close to the gingival on the primary cuspers as anchors. But as the wire straightens, we then need to replace the brackets the proper distance away from incisal edge to finish the alignment. So a deep curve of Spee usually has over-erupted permanent incisors and much lower molar positions, sometimes in a strange arc. So in order to level the teeth, you want the molars, canines, the incisors to be in a leveled and aligned flat relationship. So if you have molars that are lower and incisors that are higher, and you want to flatten it all out, then one method is to use a reverse curve arch wire, where the arch wire is actually not level, and it has a mechanics process of either raising the molars and intruding the incisors. That's a very specific arch wire that is manufactured and you can buy, but they tend to cost a little bit more than standard arch wires. And an alternative option to increase the leveling force is to bracket in different heights. So if you bracket very low in the posterior segment towards the gingiva and very high in the anterior, brackets set in a stepped relationship, right? Low, there's a tendency then to equalize the teeth relationship, because that's what night high arch wire does, right? It wants to return back to its original form. So you're artificially adding a step. So when you allow the wire to express, then the molars will come up and the incisors will come down, and it will flatten out the step or the steep curve of Spee. Once that occurs, you'll have a relationship where the molars, canines, and incisors are in a flatter position. So depending on the difference between what you want and how you've bracketed the gap between the gingiva molar and the incisor relationship will determine whether, once you flatten it out, if there's any arch wire still to express. So if you've positioned it in a reasonably accurate height differential, then when the brackets level out, the wire will have expressed itself fully and will become passive, in which case you don't have to re-bracket it. If the bracketing position is not optimal for the wire to express, you'll find that once it's flattened out, the wire is still active, and then it'll end up intruding the incisors or over-erupting the molars, and then you'll get a reverse curve Spee. So if you see that happening, then obviously you've got to re-bracket so that it's set level. In phase 1 treatment, which is what we're actually doing in postural orthodontics, we don't bother to re-bracket the arch wire so it's passive. Once you've leveled it out, you just debracket everything because you're finished. If it was a fixed braces orthodontic process, then you would re-bracket at that point, because level and aligning isn't the only step in the treatment, it's the first step in the treatment. Whereas in postural orthodontics, once you're level and aligned, you're done with the fixed appliances, so you take them all off. But in a traditional fixed braces phase 2 type treatment, then yes, you would have to re-bracket because you want the brackets then to be all in the correct heights for the teeth, before you move into mechanics, which is the next phase after alignment. Next question. If a 9-year-old with 38, 39 mil intermole width, but still class 2 division 1, will mandibular advancement improve the deep bite? I'm just trying to. So you've got a child who has a fairly good width, intermole width, but has an AP relationship, which is skeletal class 2 with tipped upper incisors. So that's what you're describing. And then you're asking, will mandibular advancement improve the deep bite? So a class 2 division 1 relationship often has a deep bite because there's no incisal contact in maximum intercussation. When you have a big discrepancy in the skeletal base, when the child bites together, the lower incisors don't line up with the upper incisors. So the upper incisors flare forward, sometimes because of a lip trap. And then the lower incisors over-erupt because the tongue is sitting over the molars and the incisors are unopposed, so they over-erupt. If that relationship, which usually has a steep curve of Spee, and sometimes a steep curve of Wilson, but usually a steep curve of Spee, then advancing the mandible might get your incisors in contact, but you'll have a posterior open bite. So unless you level and align both arches, the deep bite can't correct. So you'll need a scenario, you'll need to level and align the arches for them to coordinate. A deep bite is a compensatory coordination to allow ongoing function, even though the skeletal bases don't align. Just advancing the mandible, if there is an increased curve of Spee compensation, can't resolve the deep bite because you're not addressing the vertical component, you're only addressing the AP component. So to create good balance, you have to address transverse, which at 38, 39 appears already to be reasonable. You have to address AP, which is the class 2. But you also have to address the vertical, which is the division 1 deep bite. So unless you address all 3 components, you're not going to resolve the malocclusion. So based on that equation that you've presented, the only aspect of transverse, AP, and vertical that is correct is the transverse. So the transverse might be okay, but if we're still class 2 division 1 with the deep bite, then our AP and our vertical still hasn't been addressed. So you still have to address those components. Next question. Dr. Ramirez teaches that the primary incisors should ideally be in edge-edge position in order for the permanent incisors to erupt into class 1 relationship. Do you agree with this? So in normal ideal growth, the primary canine relationship is class 1. The primary molar relationship is end-on or maybe a small mesial step. And the wear and tear on the incisors should be at a level where you're kind of grinding down primary teeth so that you've got a class 1 pseudo class 3 relationship. The size of the upper incisors is usually slightly greater than the primary canine to canine widths compared to the lower incisor canine width. So you'll get a natural eruption path that tips those incisors forward, almost into a division 1 type relationship. And then over the course of the eruption process, they will erupt until they meet in the middle at around 10 years of age. And then between 10 and 14, the correct tongue posture will torque the roots forward. So that relationship does tend to be class 1, pseudo class 3, or super class 1, and it can be a slight edge position. Obviously, too much, and you'll end up class 3. So it's all a bit of a juggle, which is why some expansion is good, but too much expansion is actually bad. If you overexpand in the primary dentition with no thought to how things are supposed to be, then the incisors tend to erupt straight vertically down, and they meet very early, and then you'll get no forward true mandibular rotation occurring because you need that anterior open bite with the incisors erupting in a very tipped fashion for at least 2 years in order to get really good forward rotation of the mandible and the maxilla. So yes, absolutely. There's a greater tendency for it to be edge to edge than for obviously you to have a big overjet or overbutt. 6. What is the ideal width number? Can you explain what the divergence from this ideal number means? Well, width is a reference to the occlusal plane using A point and B point. Normally, width is about 0 for 1 mil. That gives you an overjet-overbite relationship of about 1-ish mil. So what's the variation? Can be minus 1 mil to 2 mils. So when it's more than 2 mils, then you end up class 2. If it's less than minus 1, then you end up class 3. So width is just the occlusal plane relationship to A point, which is approximately at the apex of the upper incisor, and B point, which is approximately at the apex, or just forward of the apex of the central incisor. So normal class 1 is 1.5 mils, 2 mils, 1 mil, somewhere between 2 and 1 mil of overbite jet relationship. So the widths should reflect that roughly. Are you currently teaching orthodontics? No. Most people don't have the bandwidth even to understand postural orthodontics. So it's not something that I'm teaching because of that reason, as well as the fact that there's just, I'm trying to teach evidence-based ortho, and orthotropics doesn't have enough evidence basis to validate it, which is one of the reasons why I'm trying to get my work published, to at least give some credibility to the methodology, which is orthotropics. 8. I am struggling to figure out cases where I should be strongly advising parents to start prior to 7 versus waiting until 7 versus waiting until 13. Can you clarify the various clinical situations where you would advise starting prior, at, or after? Is it okay to wait till the teenage years or permanent? In other words, what are the benefits we can explain to the parents of starting a skeletal class 1 case earlier than 13 if it ends up costing more money in the end? I just need to simplify it in my own head so I can explain it to parents. So every case corresponds with the majority of children establishing a permanent dentition and having lost all the primary teeth. 7 is another timeline that we choose because it's the beginning of mixed dentition. So why are we using 7 and 13? Well, 13 is permanent dentition, no primary teeth, usually hit puberty. So you have a good way of accurately estimating the finish point. You know, the arch forms and the general shape of the basal bone. You can measure the size of the permanent teeth and you can figure out the complexity of the case very easily, and you can treat according to class 1, class 2, class 3 open bite, deep bite relationships. And it's a really good time for the majority of children because there's no guesswork in the treatment strategy. Why would you treat earlier than 13? If you have a skeletal imbalance, then just putting braces on at 13 isn't going to cut it. If you have a skeletal imbalance at 13, you will be looking at using complex treatment strategies such as extractions, functional appliances, TAD, intrusion, or even surgical intervention, because you can't close the gap between the skeletal base imbalance. Why would we treat earlier or later? If the skeletal base imbalance was so significant that you needed surgery, then you would wait till the end of growth, 16, 18, 20. Equally, if the skeletal base imbalance was significant to a degree where you predict at 13 you're going to be dealing with severe malocclusion, then you might start at 7 or even earlier to try to overcome the discrepancy before it expresses fully into the teenage years. Equally, if you are screening for sleep disorder breathing issues or other medical health concerns, then you would step in earlier with referrals to ENT or sleep physician, and you would do that before 7 because the primary cause of sleep disorder breathing issues is enlarged adenoids and tonsils and turbinates in that 3 to 6-year-old age group. So if you're not screening for orthodontic issues and associated ENT and sleep issues prior to 7, then you missed the boat on optimum time for medicos to help with sleep disorder breathing. If you have teeth that are wildly out of position, then waiting until 13 will guarantee you've got impactions that require some form of surgical intervention, either in the form of extractions or surgical uncovering and all sorts of shenanigans to try to get teeth down into place. So if you don't screen for ectopic eruptions, impactions, missing adult teeth before the first decade is complete, then you lose the opportunity for phase 1 intervention. If you don't consider that skeletal class 1 relationships can still have significant transverse imbalances or ectopic eruption, impaction situations. So significant, you can be class 1 in the AP, but you can have significant crossbites. You can have severe crowding. You can have impactions. Then you miss the boat on correcting the crossbite. You miss the boat on resolving the crowding. You miss the boat on correcting the potential impactions and allowing the teeth to position into a better relationship prior to the fixed braces or aligner treatment later on. Ultimately, your decision making about 13 or before 13 or after 13 is predominantly based on whether you believe malocclusion is a genetic issue or predominantly an environmental issue. If you lean towards the camp of genetic issue, then nothing that you do will stop that malocclusion from expressing. So you might as well just let it express and then try to hide it the best you can. So this is why the majority of all children around the world are treated at 13, is because there's an underlying belief system that malocclusion is predominantly genetic. And because of its predominance in gene expression being the main driving force, anything you do before establishment of the final positions for the adult teeth is a waste of time. So if that's your belief system, then don't faff around wasting everyone's time, energy, and money treating before 13. If you believe there's an environmental component to malocclusion, then it doesn't make any sense to wait until 13 to let that environmental component have a decade and a half to express. If you believe there is an environmental component to malocclusion, then the earlier you treat the root cause of that malocclusion, the better the overall long-term outcome is, right? It's called prevention. So if you are prevention focused, which means that you believe the environment has a role to play, then you would want to treat as early as possible. If you don't believe in environmental factors, then obviously prevention is not something that's possible, and so why waste your time? That's basically what it comes down to. Now, I have put forth the scientific case for posture as being a component of significance in the etiology of malocclusion. I have put forth a scientific basis for environmental factors being very powerful forces in the development of good occlusion or malocclusion. Of course, it would make sense for us to treat different things at different timelines because they have different impacts. All right, so under 5, certain factors come into play, such as airway obstructions through enlarged adenoids and tonsils and turbinates and allergies. We have correction of posture being much simpler at that age as well. Between 5 and 10, we've established our posture so much harder to correct, and we've got compensations in the skeletal base often, and in certainly the dental alignment, dental alveolar alignment. And so you have to work fairly hard to make changes in the structure so that we can have a better chance of the permanent teeth coming through in a better position, as well as working to change the posture. And then once you're into that permanent dentition, late mixed dentition period, we've hit puberty, the bones are starting to harden into their adult form. Nothing that you do has anywhere near the impact of changing environmental factors such as posture, because the bones are hardening, and the turnover rate of cells in the bones is much lower compared to in previous times, and much higher levels of inorganic component, so there's less likelihood of easy change. Bones aren't as green as they used to be. So posture, although still very important, is less impactful when you do change it, and why so many orthodontists are happy to take teeth out, because they know they're working with the skeletal base that's fairly much set in stone. Right? So how else can we explain this? Caries management. Let's talk about caries management, okay? So are you someone who's concerned with plaque control and white spot lesions? All right, I know some dentists aren't that fussed if there are white spots floating around their patient's teeth, especially if they're primary teeth. And I know some dentists turn a blind eye to plaque that sits all over the place. It's like, yeah, if it's not a hole, I don't have to worry about it. So if you allow plaque to accumulate and white spots to generate, then over time, what happens? Well, you get brown spot lesions. And then over time, what happens? You get cavitation. And then what happens? You get caries through until the CEJ, the DEJ. And then what happens? Then you get dentine breakdown. And then what happens? Then you get pulp involvement and an abscess. Yeah. So do we let primary teeth rot? Because some dentists don't care if there's decay in primary teeth. Other dentists don't want a spot of plaque in the mouth. Another argument is, well, why bother with hygiene, plaque control, white spot lesion control, small fillings, crowns, or root canals, when ultimately you're going to pull a failed tooth out anyway? So why waste the money on prevention, restorative treatment, crown and bridge, and root canals? When it fails, you just pull the tooth out, right? So if you have that attitude, that ultimately when a tooth fails, you can just pull it out, versus you'll do whatever it takes to prevent the tooth from rotting. And if it does rot, you do a filling. And if that doesn't work, you do a root canal. If that doesn't work, you also do a crown. Or if that doesn't work, you replace it with an implant. As opposed to, well, when it fails, we'll pull it out. When enough teeth fail, we'll give you a set of dentures. Right? Because how are you going to stop the genetic breakdown of teeth through genetic causes of decay? We used to believe that, so we were happy to pull teeth out. And then one day we realized, oh, the decay might be associated with plaque and the diet and the frequency of eating and the acid um, breakdown and the recalcification, the failure to recalcify it. So we started to do restorative dentistry, conservative dentistry. So this is what it comes down to. If you believe it's an environmental cause, then you'll look at prevention of tooth decay and all the measures it takes. If you believe it's, it's just the inherited bacteria from parents who have very aggressive bacteria, so the kid's going to have rot in their mouth, and it doesn't matter what you do, it doesn't matter what they're eating, it doesn't matter if they put a toothbrush in their mouth or not, it doesn't matter if they use toothpaste or not, they're going to lose their teeth, so why go to all the effort? Let's just pull everything out and give them full set of dentures for their 21st birthday. All right, so if you have a preventive mindset, then you're talking about brushing their teeth after 6 months of age when the teeth start to rot. So this is the answer to that question. What kind of dentist are you? All right, excellent. So that ends our exciting adventure for today.
Simon, there's just one extra question. I'll copy it across. Have you got 2 minutes? Do you see it? Let me just maybe make this one the last one. Oh, did you answer this one already? This last one here.
When we do stage 1, do we have to inform all patients that they need a aligner fixed after 16 years of age? It depends on how good you are with the appliance to align the teeth. So if you're doing phase 1, then generally you'll need a phase 2 to tidy up the alignment of the teeth. So you certainly have to let people know that rarely will early intervention be the only intervention that they need. So yeah, you have to let people know that this is phase 1, it's called early intervention. We're focusing not only on correcting structural issues and maybe aligning some of the incisors, but we want to also look to see if we can improve the etiology factors such as poor posture, and the better we are at correcting the posture, the less chance you'll need complex treatment or even some treatment later on. The better you are at controlling the appliances, controlling the posture, the less treatment is needed in the future, and the less control you have in making the necessary changes in the phase 1, the more likely you'll need phase 2. Okay, thanks, guys.
Okay, thanks, Simon. All right, everyone. So we'll be here most likely next week. We recorded this if you missed it earlier on. Most of you guys are all in the case study vault or in the mentoring tonight. If you are part of the case study vault program, this weekend we are doing a mentoring. So we will email everyone the link as a reminder so you can listen in if you want. If you're not getting those emails, do send us an email at info. I know some of you haven't completed the 30 hours of prerequisite before you can join the live mentoring calls and listen in. But anyway, send us an email if you are not getting notifications. But tomorrow we will notify everyone who are part of the Listen and Learn Only program. All right, we'll see you guys. Thanks for your questions, everyone. We'll see you soon. All right, take care. Thanks.